Good afternoon, and thank you for joining us. There are over 350 registrants for today's discussion on the impact of COVID-19 on child and adolescent health, including physicians, faculty, students, trainees, social workers, administrators from multiple schools and community organizations. Today's webinar is sponsored by the Harvard Medical School Office for Diversity, Inclusion, and Community Partnership, otherwise known as DICP. The mission of DICP is to advance diversity and inclusion in health, biomedical, behavioral, and STEM fields in ways that build individual and institutional capacity to achieve excellence, foster innovation, and ensure equity in health locally, nationally, and globally. DICP efforts support the career development of junior faculty, trainees, and students, identifies and trains leaders in academic medicine and health policy, and provides programs that address crucial pipeline issues. Today's webinar is offered through our DICP Equity and Social Justice Initiative. It is the third ESJ webinar in the current academic year, and a little bit of our history. In the fall of 2016, a planning committee comprised of faculty, staff, and students representing the Harvard Medical School community at large discussed the establishment of an equity and social justice series to address health disparities, social determinants of health, leadership in the health system, health policy, and other areas affecting vulnerable populations. Since 2016, an average of 10 to 12 programs have been provided annually and in collaboration with our Harvard Medical School affiliated institutions. ESJ events focused on 4 areas. 1, history and context. 2, culture and environment. 3, health disparities. And 4, leadership and skills development. This year, the ESJ lecture series tackles health issues that often impact disadvantaged and vulnerable populations. Our conversations and speakers will address not just defining the disparity, but will discuss interventions on a community, hospital, or health facility and policy level to address inequities. As we start, a few housekeeping notes. The chat is not available. Your microphones will be muted, but you can use the Q&A to post questions to the panelists. This webinar is being recorded and will be posted on our DICP website. And now it's my pleasure to introduce Dr. Alden Landry. Dr. Landry is an emergency medicine physician at Beth Israel Deaconess Medical Center and is the founder of Motivating Pathways, Inc., an assistant professor in emergency medicine at Harvard Medical School. He's also an assistant dean in the Office for Diversity, Inclusion, and Community Partnership. And with that, I'd like to turn the program over to Dr. Landry.
Thank you, Dr. Reed, for the introduction, and thank you to everyone in attendance for joining us for this discussion. We're going to talk about the impact of COVID-19 on child and adolescent mental health, and I think we have an amazing set of panelists. These two are really going to help us to think about these issues, the mental health crisis that we're experiencing with our healthcare system and the impact of COVID-19 on child and adolescent health. And so I think without further ado, I'll just go ahead and jump into introducing our panelists, and then we're going to get started with the conversation. I've known both of these panelists for a while now, so I know that they're going to bring a great discussion to this topic. As Dr. Reed mentioned, the chat is closed, but if you do have questions for our 2 panelists, be sure to take advantage of that, to use that to ask questions to the panelists. I'm going to first introduce Dr. Kamilah Jackson. She's the medical director at Perform Care. And more importantly, she is a alum and a friend. She and I did participated in the Commonwealth Fund Fellowship in Minority Health Policy back in 2010. And we were classmates through pretty much the entirety of our NPH. Next is Dr. Kevin Simon, who is an instructor at Harvard Medical School. He's an assistant professor, assistant in psychiatry at Boston Children's Hospital and a 2020 Commonwealth Fund Fellow in Minority Health Policy. And with that, we're going to just go ahead and get started with questions. And Cam, I want to turn to you first. And can you really just set the stage? What is our current status of the mental health system that we are experiencing with a particular lens focusing on child and adolescent health?
Sure. So I think our discussion today is so timely, particularly because of some of the national pushes that we've seen. So just 2 days ago, the Surgeon General issued a youth mental health sort of call to action with an advisory that's going to roll out next year, calling to attention the fact that we were heading into a crisis even before the pandemic with regard to child and adolescent mental health. And we're certainly there right now. And I think this discussion today will even bring that to bear even more. What we knew going into COVID was that regarding children's mental health, 50% of lifetime mental health disorders have an onset before age 14 and 75% before age 24. So childhood is an important, critical time for thinking about the emotional and mental health of youth. Suicide was the second leading cause of death for teenagers. And this is a stat we knew prior to the pandemic, and it's borne out through this time as well. And we've seen that there are issues with young people engaging in schools and their communities and their families. With the suicide crisis, there was a particular attention to Black youth who were not prior thought to have such high rates of suicide, but from recent data, that's become pretty clear. So that was all before the pandemic. What we know now is it's gone to an even more stark situation. And in October, the Child Psychiatry group that Kevin and I are a part of, National American Academy of Child and Adolescent Psychiatrists and the American Academy of Pediatrics, partnered with the Children's Hospital Association to really call at the federal level to highlight that there's a crisis happening now with children's mental health. We see this in the emergency rooms. I know Kevin's going to talk about this a little bit later, but what's happening before kids even get to that emergency environment is, I think, where we need to do a lot of work. But in short, we're in a crisis right now.
Well, thank you for that, Kim. I think it's important for us to just admit where we are, and we're in a tough spot right now. But I want to turn to you, Kevin. Cam painted the picture. Why are the numbers so bad? What is happening, and how much of this is an impact of COVID-19?
Yeah, so everything that Cam says or said, I'm in essence going to piggyback off of in reference to why are numbers so bad. And when we say numbers are so bad, from a hospital system standpoint, in both 2020 as well as 2021, we saw a larger influx of youth coming to hospital systems looking for emergency behavioral health or mental health care, some who required inpatient hospitalizations. From an inpatient hospitalization for psychiatry, there just were not a lot of beds available and continue to be a shortage of beds that are available. So you'd have a lot of youth and families, in essence, quote unquote, boarding, in that they would be waiting for a bed just in the emergency room, sometimes in the hallway, which is not ideal. You compound that with there were shutdowns. So you can think about schools not being open, specialized schools not being open. And so here it is that you have youth who in essence get about up to 40 hours of kind of observed education, observed environments where there's teachers, there's school counselors that are available. Now you just remove that, and then you have youth now at home with parents who are attempting to work from home. And then there's actually a large number of youth who lost parents because of COVID, right? So a whole host of factors, multifactorial. The system was not designed to operate under this environment. The mental health system was not designed to operate under this environment. There are not enough child psychologists, child psychiatrists, behavioral health school clinicians. So now even with school coming back in person, we're still seeing, in essence, record number of persons coming to the hospitals seeking care. And then in terms of outpatient services, most both private and academic services are at capacity. And what I'm hearing and seeing is wait lists of several months, where that usually was not the case for behavioral health. It wouldn't be, let's say in 2019, it'd be fairly feasible to get an appointment with a child psychiatrist or behavioral health clinician in a 6-week timeline. now, even in systems that I'm in, we're currently in December, we're talking about having appointments for new evaluations in March. So the system just was not designed for the kind of capacity that we're having right now.
You know, it's interesting, and I want to touch back on this maybe later on, but thank you for bringing it up because I think it's really important for us to think about the stresses that are on the system. You mentioned what's happening with the workforce. From my understanding, and you can help correct me if I'm wrong at a later point, is that, you know, it's not just about the providers being available, those with, you know, the MDs, the DOs, the PhDs, the psychiatrists, the sociologists who are available, but also just having the staff at facilities who are able to work with the patients day in and day out in order to just to keep the doors open at the facilities. So COVID has had just an impact, just, you know, even deeper. And we often think about this at the very high level of having the providers available, but there's the infrastructure that's impacted because the people who are part of food services and environmental services, the nursing staff, they're just not available as well.
Yeah, so, you know, I know Cam can talk to this, but within Massachusetts, so just for instance, there's a state facility that caters to developmental disability youth or persons. That facility classically can hold around 100 to 150 persons. As of today, that facility has about 40 persons. And that's in part because, to your point, staff capacity, what's required to care for certain types of people. So right now, there are a lot of systems, even school systems, where we just don't actually have staff available to help with the needs of youth. And so that then comes back home. And so you have parents who are, again, trying to multitask, or trying to be at a job on Zoom, and you have a son or a daughter or multiple sons and daughters that are having their own sets of challenges. It really does create a very frantic environment that we're in.
Thanks, and I'm sure we can jump back into that a little bit more later. It's something I think is a really pressing issue that we need to talk about. I want to turn back to you, Cam. You know, one of the big things we were concerned about back in March of 2020 when the country shut down and schools were closed was going to be the impact of student performance in school. Now that students are back in school, there's definitely a lag in how students are doing. But can you just talk about the impact of COVID on performance in the school, how children are behaving, and issues that you may be seeing or hearing?
Sure. So I think a lot of the challenges happening that we're seeing with children going to emergency rooms, as Kevin pointed out, have to do with some of those issues with engaging in the school environment. From the data that I've seen, it seems like younger kids are actually adjusting a little bit better to this transition back to school. Teenagers were really severely impacted during the pandemic, and a lot of the data really talks about the increased anxiety, depression, and suicidal behaviors that we saw in them. And it makes sense developmentally. You think of teenagers, and your life as a teen is engaging with your friends and really trying to separate out from your family, and especially with the physical distancing that we had last year, teenagers, particularly, for example, LGBT teenagers, who really seek support outside of their environment sometimes because they can't get it from families, really struggled the most in terms of anxiety, depression, and suicidality. So we're going back to school right now. We lost some time in terms of the intensity of the education that was able to happen. And by the way, even summer services were impacted, right? So camps, a lot of the staffing issues that we are talking about impacted camp environments where kids have some sustainability and transition between the school years. So we lost track during that time. I know a lot of schools are really doing the best they can in terms of trying to support kids coming into their environment. But again, they also have some of those workforce challenges that we've been talking about. So we're seeing it across the board, but I think in particular, there's concerns around how teenagers have been transitioning back to school. With younger kids, they seem to, be getting easier back into the routine, although for some young people who had pre-existing mental health conditions, those have continued during this time.
Thanks. And I want to turn back to you, Kev. We were talking about this recently. Can you talk a little bit more about the access to care issue? Specifically, the vantage point that you and I were talking about is my experience as an ED physician, taking care of patients with mental health disorders coming into the emergency department, particular pediatric patients. And then unfortunately, there's just no beds available and the length of time that these children are unfortunately in the emergency department. So can you talk about some of these access to care issues specifically with emergency situations?
Yeah, so a beautiful thing that has happened is exactly what we're doing, right? Zoom and telehealth, telepsychiatry, which was in existence before the pandemic, certainly ramped up to a degree that we hadn't seen. And so I can say in departments that I work in, our no-show rate like dramatically declined, and the number of persons that we were able to see increased. But bandwidth, internet, Wi-Fi, unfortunately isn't equitable within society. And so there were some families that continue today where despite sending them a Zoom link, may not be able to access said Zoom link because it's the grandmother that's the guardian, and the grandmother isn't necessarily tech savvy. And despite a lot of people having smartphones, may not recognize how to get Zoom on an app. And so there still were a lot of telephone calls that still today happen for some families. This other access issue is if someone does come to the emergency room, oftentimes emergency room physicians, pediatricians will feel comfortable, quote unquote, discharging a patient if they have a plan. If you did not have a therapist, did not have a psychiatrist, did not have some counselor, well, what's the family supposed to do? Wait. And so then when you call said outpatient provider, hey, we're in crisis, it's actually the type of, youth and family like, well, is this when you want to, have our first appointment, like just coming out the emergency room? And then I actually can't see you in person, I have to do it via video. It makes it challenging from a system standpoint. I can say anecdotally, I've had youth who, and these are well-meaning parents, our appointment was at a 2:00 hour. I log on and they're talking to me and I can just sense something's like different. And I said, what's going on? And literally at the 11:00 hour, there was like a near fatal incident. And I said, I know we're meeting now, but why didn't you go to the emergency room? They were like, well, we knew we had your appointment. And so whether go to the emergency room or we just stayed with him in the room, we figured we'll just stay with him in the room for 2 hours because we have you. And so, it's created a lot of scenarios that we're not very familiar with. So the access issue is we have patients who do have providers, but for some sets of kids, you actually need to see them in person. It's very easy, and I'm just gonna do it now. It's very easy to put my hand in front of the camera and say, I don't want to talk to you. It's easy to just close the laptop. And so because sometimes different variants are forming, different rules are in place in terms of who can come in, who can't come in, it definitely has made it more challenging to see some of the high-risk youth in person because our clinics are such that providers are working from home. So there, again, the staffing issue, there may not actually be people in the clinic to be seen to see patients. So access has been a challenge. I know for sure children, this is the last point, Children's has attempted to ask different staffers if they know of families that might need a laptop or might need an iPad. And there have been some donations made by different foundations so that way we can get that to families. But again, depending on who's the guardian, a laptop, iPad might get to a household or an apartment, does not necessarily mean they're going to know how to operate it such that they can see me or any of my colleagues.
If I could just add quickly two specific populations of youth that I think with our virtual solution, while it's been great, that challenge you talk about with in-person will likely continue, Kevin, is really young children, right? In terms of engaging virtually. For teenagers, this is their life. This is how they engage with the world. But for young people, this is becoming a natural way for some younger kids, but still not in terms of actually sitting through an intervention over the camera. And then also for youth with intellectual and developmental disabilities, it's been very challenging to do virtual interventions for those populations.
And just one last point, you know, given how much we're living and operating online virtually, a significant challenge in homes is quote unquote screen time, right? So it's very odd, and I will admit it's very odd to be talking to someone on a screen, and then my recommendation is try to somehow minimize screen time, right? It's just this double entendre. It's like you're telling my parents to limit my screen time, but I'm talking to you on the screen, Dr. Simon. So again, you can see how these challenges come up, particularly for younger youth. I just wanted to just highlight that because that's happened several times in personal interactions.
Well, you know, and I actually want to maybe stick with this topic of virtual interactions, because I think we're reaching into a space that we weren't originally planning to go to, but I think there's some more meat on the bone. And I wonder, is this actually providing you a better window into the patient's home, into their lived experience, compared to an office visit, or the fact that a family would have to trek, you know, maybe midday during school to get the child to the appointment. So it sounds like there may be some pros to this as well, but in addition to the cons, what do you two think?
Yeah, so in reference to the pros, so anxiety is our most common diagnosis, just generally in terms of mental health conditions. And there are a number of patients who would have social anxiety, where when they come into the clinic, they don't talk. They will stare at me and not say a word. Parents will be in the waiting room, and those youth light up in their comfort of their room and will show me what's on their wall, the anime, etc. So there are these. It's unusual, but there are these populations where being inside the home is definitely more helpful for engagement. But there are some say that they're depressed, just will not look at me, will, you know, have their hair shaggy, just covering their eyes. And I'm like, you know, I can't see you. But in terms of that glimpse inside the home, you actually then you know, are you in a private space? And they're like, well, I share my room with my two sisters. So this is as private as it's going to be. They're going into the bathroom to have a session. So you can see some of the logistical challenges to try to have a normalized, safe environment when for some youth and some families that may actually not exist, to have a space for yourself to have an appointment.
I definitely agree. I think being able to see inside the home, although it's the part of the home that the child and family want you to see, which I think is part of the restriction. You know, prior to the pandemic, I did home-based work, and it was always such an amazing opportunity to be in the community, to see what that's like, to see what the environment's like, to see what inside the home is like. But we have a very circumscribed window to do that with virtual, although it's been great to have access. You know, with the school shutdown, schools are so much of a place where kids' behavioral health needs are identified, as well as abuse and neglect issues. And so I think also with virtual, it's difficult to get that sense of, you know, is there something additional happening within the home that we need to be concerned about? And we certainly saw child abuse reporting rates decrease in the early part with the shutdown, and those seem to be ticking up slightly with some of the going back to school, but you're not able to see that and appreciate that as much in the virtual context.
And thank you for that point, because I did want to talk about child abuse reporting and what's happening, numbers as far as going down and going up. So thank you for bringing that up, because as we talk more about the schools and their interventions that they should be doing, I think that's something we should maybe draw and highlight a little bit more. But I do want to stick with you, Cam. Can you talk to us about, for those of us who are parents and those of us who are caregivers, what are things that we should be considering? What are some signs that we should be looking for? And how do we know when to seek professional services for our children?
So I think it's probably been the hardest to be a caregiver during this time, because caregivers are all going through all of this with their kids, right? And the advice that Kevin and I will often give is your kids look to you as the model for how they should move through challenging situations. So your stress and your rates of anxiety and depression have also gone up. You've been dealing with loss, you've been dealing with employment issues, et cetera, but we're asking you to, as much as possible, try to be calm, supportive, encouraging, working with your child. So that's been, I think, the biggest challenge I've seen in terms of interacting with caregivers. For what to look for kids, we always talk about changes in their routines or changes in the way that they normally do things, right? So are they withdrawing from their peers, not wanting to engage as much during this time? I know with screen time, a lot of parents have allowed video games and other things to increase while they were trying to have them decrease before the pandemic, but are they not even interested in things that they have been wanting to do as much before? We look for also changes in sleep, appetite, eating too much, too little, change in routine, engaging in, now we have sports that have opened up and things like that. Are they not wanting to do those usual things that they were able to draw some pleasure from in meeting? And also just not interacting as much in their family environment and context. Now with school back in session, a big warning sign is around school, how they're doing in school and engaging in that context. And then for teens, especially thinking about substance use, I know that's something that Kevin can speak to very well, but we do look for indications that they're engaging in use and some of those patterns. Anytime these symptoms start impacting how a child functions, so for kids, school is the biggest part of how you function. You don't have a job as yet. That's how we look at adult functioning. Those are really when we would say seek help. Usually the first place to start is with your pediatrician, but seek, raise a red flag to say, I'm really worried about how things are going. But the first part, I think, is really checking in with your child and creating that space and openness for them to be able to talk to you about how they're doing. So if you have a regular routine of, before we go to bed, we talk about, what happened during your day, how are you feeling? If you need to share how you're feeling and how you're being impacted in a way to help normalize for them some of the feelings that they may be having, do that, model that way for them, but really try to have that emotional connection with your child in that open space for them to share, how they're doing, what struggles they may be having.
Great. And one of the questions I had for you based off of that, and just to stick with you a little bit longer, is you mentioned going to the pediatrician. And so can you talk about, maybe for those pediatricians who are on, how do you broach some of these tougher situations, get this information either from the parent or child? Any suggestions or recommendations there?
Yeah, I think pediatricians are amazing at having a finger on the pulse of kids. Pediatricians really understand development and milestones and what may be going on. In my experience, the struggles have been, if I identify something, what on earth do I do about it, right? That needs a deeper intervention. And so I think pediatricians checking in with young people about, what's going on with them, what's happening in their lives, especially with teenagers, having that opportunity to access them outside of their caregivers so that they can share a little bit more with you. And then from my perspective, I think the identification part has been less of a challenge than the intervention part for pediatricians, right? Like what to do next. I know we're going to talk about some potential solutions coming up, but that's where I see most of the needs arise in terms of what to do for support.
Right. And then Kevin, we often frame this as, the issues related to the individual, to a patient doctor, patient provider perspective, but really there's some policy implications to all of this. And we need to, in order to think about real lasting sustainable interventions to address the mental health crisis that we're having with child and adolescents, we need to think about this from a policy standpoint. So can you start to help us think about ways that we can develop policy at whatever level it may be, whether it's at the school board level, whether it's in a hospital or in a locality or a state level, or even a national level, what policy interventions can we put in place now that are going to start to help to alleviate some of the aspects of this crisis?
Yeah, so it's a good question. It's going to dovetail off of Dr. Jackson's last point. So, thinking we can start, I guess, statewide. So within Massachusetts and just a few other states, so I know New York's another one. So we happen to have the Massachusetts Child Psychiatry Access Program, or called MCPAP. MCPAP can certainly be more well-funded, such that you could be in the western part of the state or the northern part of the state or southern part of the state. If you're a pediatrician and you do recognize that someone comes in with behavioral health concern, or you've done a substance use screen, and has been the case, I've met pediatricians say, oh, I have a 18-year-old who's identified that they're utilizing opioids. Our MCPAP system is a line where, Boston Children's Hospital, Mass General Hospital, several of the academic institutions have child psychiatrists that are available to provide a phone consult to the pediatrician to give some recommendations about what would be the best option while we're waiting for the wait list of said clinic to, whittle down. So, buffering and providing support to programs like that, I think is something that definitely each state can do. Now, Massachusetts is unique in that we have a number of academic hospitals that have child psychiatry programs. And so there may be some other states that have less availability, but given that we can do virtual consults, phone consults, that is how we widen the access to individuals. In terms of schools, so again, this could come from city funding. How are schools being, how is finances being allocated to different regions? Generally, it's based off of housing and school districts that are in better situated counties get more funding. The reality is funding needs to be spread equitably, in that if there are schools that have a higher percentage of youth who will require more behavioral health services, then those schools need to have more than just one behavioral health clinician. When there are other schools in different counties and different districts that have less students and more behavioral health counselors, right? So the equitability in terms of school system, we see this in the Boston public school system, has to be better situated. And then in terms of, if you want to look at nationally, so there are funds that are looking at how can we bolster the mental health services, but given that there are cracks from trainee standpoint, so we need more funding for training social workers, psychologists, psychiatrists, med school funding, graduate school funding, for persons from underserved populations to have an opportunity, loan repayment, so that way folks say, oh, you know what, mental health is a field that I want to go into, and if I do work with this clinic or this institution, perhaps I can get some of my loans repaid. This is how we can get more individuals that are diverse into those careers. So the policy perspectives are individually based as well as state and national. And we just mentioned a few of them. In terms of funding for hospitals, so you name the hospital, there's probably not enough psychiatric beds at that hospital. And that is in part from policy years ago that likely do need to be changed, so that we can have more than just teenage number of beds. So 15 beds is not equitable and not enough when you have 45 persons waiting in an emergency room or boarding for a bed. So there are a lot of ways to work at thinking about policies to improve capacity for youth and families.
I absolutely agree, Kevin. And I think given our conversation today, one of the unique windows I think we have as child psychiatrists is that this is also a structural inequity issue, right? So mental health is often the stepchild of the healthcare system. And children's mental health is actually the stepchild of the mental health system in terms of our policy, our funding, our resources. And I think we didn't come to this crisis accidentally. we have not really recognized enough the importance of social and emotional development of young people. And you can see that in a number of ways that play out in resources in schools, how we support pediatricians, what happens in the child welfare system and juvenile justice system, and even just our national sort of dialogue and language around mental health. I think the stigma that exists as a society has impacts pervasively. So I'm really, hopeful, and we'll get to that at the end, about the fact that we're having these conversations and finally recognizing, and it's sad that it takes a crisis, but we know in the policy world it often takes that to really bring the solutions that need to come forward.
Great points. And I want to go stick with you, Cam. One of the things that we talked about earlier was the increased use of telehealth services and how we are, for better or for worse, relying on telehealth more for access to care. And I guess just from a more practical perspective, how do we know, how would I know as a person if the situation is reputable, if the provider is reputable, if we're putting our child in the best position to get the help that they need?
I think Kevin might have some ideas for, we were talking about this a little bit earlier, because there have been so many digital solutions that have come up, right? I think the private industry has really seen the opportunity in the crisis that's happened here. The advice I give folks, and again, it's a challenge because of the workforce, is to look for licensure, right? So you want to look for clinical licensure, especially for social workers, other clinicians who may be working with young people. And then board certification for us, for Kevin and I, that's a really important standard to meet. Those are the two things really concretely around licensure and board certification that exists for therapists of all stripes, including therapists who work with young people with intellectual disabilities, et cetera. So looking for BCBAs, which is a credential in that area, but like the workforce issue is going to be the thing. I think that's the challenge in finding that, because there are some other places that have come up and they're really looking more at kind of coaching, and they're Kevin, you might want to jump in here just based on some of the things I know that you're seeing.
Yes,
it's tricky.
Yeah, no, this is extremely challenging for families because there's a lot of influx from private industry in terms of quote unquote digital solutions. And I think it's very incumbent upon family to be as best educated about the type of providers they're going to engage with. And so if you can't Google or search on your own, definitely asking upfront, what their licensing process was, because, for some conditions and for some just emotional states, perhaps talking to somebody like your friend or someone in a church system is fine. And I'm not negating that that's not appropriate in some scenarios, but there are other scenarios. If someone is suggesting suicidal ideation or thinking about suicide, or really wants intervention for a substance use disorder, you want someone who's been trained to identify that and trained in interventions around that. And so sometimes when you hear certain phrases like mental health coach, that may be an unlicensed professional working for a company, and the company gets to say, we provide mental health services, but it's actually not licensed credentialed services. It's just the label mental health coach. And because there is a crisis and people are looking for mental health services, the catch of mental health in front of the word coach does lure some people in. So it's very important to really be able to identify accrediting bodies. So again, American Board of Psychiatry and Neurology is what board certifies a physician to be a psychiatrist. So very important for parents to seek that out because, markets themselves and private industry themselves will do things that are financially lucrative for them as a system, and may perhaps not be as beneficial to the patient side.
It's interesting that you're bringing this up and just thinking about licensed and board certified and credentialed individuals, mental health providers. And I just wonder, as we think about this even deeper, we think about the importance, or is there an importance of racial concordance, or between the patient and the provider? How much of that matters, especially to these vulnerable youth who are in these situations where they're suffering from a mental health crisis. I know that the workforce is limited when it comes to Black, Latinx, Native American physicians, specifically child and adolescent psychiatrists, also thinking about social workers, how there is a relative paucity of diversity within those spaces. Same goes for psychologists. So any thoughts about the importance of that concordance and ways to address maybe some of the cultural nuances that may be happening in these situations?
Yeah, so racial concordance, or the patient and the provider coalescing around culture is important, and there's a lot of evidence to suggest that when race of patient and provider are the same, recommendations might be better attended to, right? I can say personally, I have had families reach out specifically to me because I'm African American, I'm a male, and their youth is African American and male. And so they would like me to be their specific provider. But given the shortage, in the city of Boston, I'm one Black male child psychiatrist of probably less than a handful, right? In a city that has millions of youth. So there have to be providers that are comfortable treating patients that do not necessarily look like them. This, in terms of the licensing piece, this actually has created quite a challenge in that families actually have, at least for myself, families have sought me out that are out of state and even out of country. And they're like, well, can't you see me virtually? And it's like, technically I can see you virtually, but the way that our laws and policies are set up, I'm actually limited to only treat and provide services for persons that are within the state that I'm licensed in. So again, it's another policy thought and that we need to have, because if I can provide services to a family that's in Iowa, because in Iowa or any other state that has even less number of diverse practitioners, why should I not be afforded the opportunity to provide service to that family who's seeking it? So it brings up another policy question that I think we have to think about in a new way, given the types of platform that we are using to provide services.
Kim, did you want to jump in?
Yeah, I agree. And I think even outside of that, so Kevin and I represent, I think it's less than 3% of psychiatrists in the country are actually Black. So there's never going to be that opportunity for one-to-one racial concordance in the population. I think that thinking of what the healthcare system is doing in terms of training around structural racism and cultural humility with the workforce writ large is going to be very important, because most of the kids, especially in the context that I'm in, are Black and Latino. And there's just not an opportunity for them to have a social worker, much less a child psychiatrist who's also Black and Latino, which means then that the people that we are entrusting with their care really need to do their homework and beef up their skills around understanding the impacts of structural racism, understanding the impact of inequity, and really being humble about, not being from where they are, but wanting to really join with them and helping them and supporting them.
So I think we've taken, a deep dive into the crisis, why we're here, some of the policies that can be put in place to think about ways to help our youth. But I want to try and sort of move to thinking about, things that we can do, and hopefully in this conversation more on a positive note, but we'll see how it goes. I think this is just it's an important conversation to have. And if we have to have sort of this deep dive into a tougher space, I think we have to be a little bit uncomfortable in order to get to where we need to be. But Kevin, can you talk about some strategies that we could be putting in place to strengthen mental wellness on the individual level?
Yeah, so I think in terms of what like employees can do or employers can do for parents, in terms of paid time off is critically important. A a lot of times I'm telling parents, because they'll ask, what should I, are you taking care of yourself? Because if you're not taking care of yourself, you're gonna have such a shorter bandwidth to take care of your child when they're experiencing some behavioral challenge. So, seeking out employment opportunities that do provide paid time off for parents. I think another thing that individually from a youth perspective, we do need to have environments that cater to diverse youth. So participating in group activities, be that the traditional soccer, football, karate, or chess, if your son or daughter is not athletically inclined, I think providing funding for that is important, be that the YMCA, the Boys and Girls Club, because there are populations where they'll say, Dr. Son, I can't afford to bring my kid to X service. So I think there are ways that funding can be given to certain organizations that then can take on capacity to hire more staff, as well as provide services that generally tend to improve the wellness and health of youth. So those are a couple of small, I think, things that are tangibly and that can be done quickly, that don't take too much consideration.
Thanks. And to you, Cam, are there strategies or recommendations that you have for us to improve with our parent-child communication so that things are going smoother in the house?
Yes, so I think what we talked about a little before in terms of open communication, a lot of kids will say, well, you asked me to tell you, and then you punished me for what I said, right? Or you had this overwhelming reaction to what I said. So really establishing that open, honest pathway for talking to your child about, what's going on with them, what are their struggles, what some of their stressors are. I think for kids, even teenagers, I say this a lot because teenagers oftentimes seem to want to say that they don't want structure and routine. We all actually crave structure and routine, right? And I recognize how challenging that is when things are so uncertain to try to do that. But I think for families, as much as possible, to try to have still some structure and routine embedded within their family life, so that kids can have some sense of expectation about, what's happening. If I can't control what's happening outside the door, can I control or understand what's happening within my home? I think that's a huge way that families can start to support their kids in a more meaningful way, as well as through those routines, trying to establish some structures around just, bedtimes, regular times to eat, regular times to have dinner, meals together. And a lot of families were having more meals together during the early kind of lockdown phase than they ever did. How can we keep track of some of those routines that we were able to set up that were really girding us against some of the uncertainty that we were feeling? I think a lot of the pieces that Kevin also talked about is how can we just overall support families better, right? Supporting families is supporting children's mental health. That's a really critical thing that we need to get across at the individual, but then also at the state, national policy levels.
All that I in reference to what in terms of communication, one thing that I generally recommend for families. So as a parent, and I know a lot of parents, we like to provide solutions to things that we hear, and I often say, you should designate a day and some time, and that time is 10-15 minutes for what I would call just a listening session. You hear whatever your kid says about whatever it is, but you don't have to provide, and you actually should try to refrain from providing some form of a solution. A lot of times we actually just want to hear and feel validated about the concerns that we're bringing up, and not necessarily hear, well, you should do this, or why don't you do that? And so if there's this 10-15 minute period where your kid just talks and just listens and you just validate that feeling, that actually goes quite a long way. And if that becomes a routine, then your child actually wants to come and tell you information when you would want them to tell you in the event that they're in a crisis. A lot of times parents are surprised to learn about the concerns that their children have. And when I talk to youth, they'll say, yeah, I'm not going to tell my mom this because she's going to overreact. So just listening without wanting to provide an answer, I think is actually pretty critical skill to develop for parents and children so that they have clear communication.
That's awesome. And while we're on this point about communication, and we mentioned earlier about the schools in this, any recommendations or thoughts on better communication between parents and schools, parents and educators, how we can make sure that we're doing our best to protect our youth?
I actually like what Kevin suggested and really think of that in terms of the education system as well. So sometimes parents are really very afraid about educators or anyone in the school building learning what's happening at home because of how that information may be used. And so I think part of, we talked about the professional workforce, but we really didn't hit on the other workforce outside of pediatricians that also need to be educated about the importance of social and emotional health and how to intervene in their own ways through their own roles. Educators, sports team coaches, et cetera, really need to have increased literacy around social emotional health and how to support young people. But I think as much as possible for parents to try to engage in those conversations, whether it's a teacher, the counselor in the building. We know there are not as many of those resources as we need right now, but there are opportunities there to enhance that level of communication. It's especially critical, we've seen, for young people who have pre-existing mental health conditions, right, to be able to have those opportunities to work closely with teachers and folks in the school building. Many schools have what's called a child study team, which is supposed to be a team of individuals within the school who are looking at young people who may have needs that are arising to, needing some level of attention. So parents can ask about what resources there are within the school building to be able to support their child, because those are legislated types of resources that should be available for young people. So working within those contexts as well.
Yeah, and the other thing I'd mentioned in reference to schools, so a lot of times, and this happens for families that are tend to be marginalized. Families may not recognize what is legislatively afforded to them if you have a child that has anxiety, depression, ADHD, or any other condition. So federal statute 504 plans, so accommodations, and then if the accommodation plan is not being successful, then IEP, or individualized educational plan. If you're in a public school system or even in a private school system, sometimes every child is afforded an opportunity, if they have a mental health condition, to potentially seek out having accommodations in the school setting. So might it be that Johnny has to get extra time on a test, or if he or she is feeling frustrated, can go to the nurse. But that can be part of a document that indicates this is a part of his or her plan, and not negatively documented that we have to take him out of school. So I think being educated about what's afforded to youth who do have behavioral health concerns is important, and can be a conversation with a pediatrician or any mental health counselor that the parent has access to.
And we're coming near the end of our presentation, and I just want to say thank you to the audience for listening into this conversation, and thank you to our two panelists. And I want to end with a question and pose it to the both of you. One can answer. Are there reasons to be optimistic? We've been in this pandemic for the past 20 or so months. Unfortunately, we're seeing variants that are happening. We know that there's lots of issues that are happening in schools right now. We talked about the strain, the crisis that we're in right now, but are there reasons to be optimistic as we approach this holiday season and entering into the new year?
So I'm going to jump in first and say yes, overwhelmingly, actually, despite all the things we talked about this afternoon. One is, again, just because of where we are in terms of recognition, right? I think this is a really amazing opportunity to have, the Surgeon General, which last time the Surgeon General talked specifically about mental health was in 1999, and it wasn't specific to kids, right? So this is specific to young people, and really setting a course of actions to really talk about how we improve mental health support across the board, not just on the treatment end, but really from promotion to early intervention, even before we get to treatment. So I think this is a different conversation than I've seen in my last about 17 years or so in the field. I think the other reason to hope is because of young people, because what we know from the work that we do is that young people, despite all of the things and challenges and stressors we throw at them, are incredibly resilient. I think that's the beauty of development, and that we still have time to intervene and provide support. And so I think it's the young people that I work with and try to support at different levels that really give me hope. And I know as parents that we're worried about how they're doing, but I think the message that I want to leave folks with is that treatment works, right? I know it's hard to get to it at this point, but I think there are a number of things coming down the pike in terms of interventions that we've known we've needed, but there's seemingly more funding coming after some of those things. So I think those are all reasons to really feel hopeful at this point.
And Kevin?
Yeah, being mindful of time, I would completely agree with everything that Dr. Jackson just said in terms of the fact that we're having this conversation. There is more funding coming down the pipeline. So certainly I am hopeful and optimistic about the future of child mental health.
Awesome. Well, I want to say thank you again to the audience for joining us. I want to say thank you to both Dr. Jackson and Dr. Simon, two great friends of mine, for being here in this space. Thank you to Jasmine for doing the background work to get this off the ground. And thank you for Dr. Reed for your continued leadership in the space in the DICP. If you take a look, there's a few upcoming events that we're going to be hosting for the DICP. These events are always open. There's a brief poll that we would ask you to participate in. Doesn't take long to click through. And just to give you a heads up, we have future equity and social justice discussions that are going to be happening in the near future, having a conversation around the impacts of incarceration on equity and social justice. We're going to have a conversation around climate change and its impact on health equity. Look forward to seeing you participate in those events, as well as the other DICP events. Please visit our website for more information about these events, as well as the recording of our discussion today. And again, thank you for your time, and everyone have a good rest of your day.